Welcome back to this next video in which we are discussing coronary artery disease. Okay, so when we discussed myocardial infarction as acute coronary syndromes, we divided them up into two types. There was the subendocardial myocardial infarction and the transmural myocardial infarction. And remember, in the subendocardial myocardial infarction, the thrombus that is formed on top of the ruptured atherosclerotic plaque has not completely occluded blood flow. It's occluded it hugely through the blood vessel, but it hasn't completely occluded it altogether. So there's still some blood flowing past the thrombus and getting to the subepicardial myocardium and preventing that from becoming so ischemic that necrosis ensues. However, the subendocardial myocardium, which is supplied after the subepicardial myocardium, that is getting bad enough ischemia that it's actually going to die, it's actually going to infarct. So you get a region of infarction that's subendocardial. Meanwhile, in the transmural myocardial infarction, the thrombus that forms on top of the ruptured atherosclerotic plaque is going to completely occlude the blood vessel, and therefore you're going to get no blood flow at all through the blood vessel, and therefore all of the myocardium that is supplied by that blood vessel is now going to undergo the infarction process, the necrosis process. So you get a full wall thickness infarct, in that case a transmural infarction. Now, the reason I have stressed the difference between these two types of myocardial infarction is because they appear different when you look at the ECG of someone who is suffering from the two different ones. So a subendocardial myocardial infarction, this appears on the ECG as what is known as a non-ST elevation myocardial infarction, or an NSTEMI for short. So N is for, I'll write this out in full, so non is the N, then the ST is just for ST, and then it's non-ST elevation, so the E is for elevation, and of course the MI is for myocardial infarction. So when you look at the ECG for someone suffering from an NSTEMI, a subendocardial myocardial infarction, and indeed these two terms can be used interchangeably, NSTEMI or non-ST elevation myocardial infarction or subendocardial myocardial infarction. From now on they all mean exactly the same thing. When you look at the ECG for someone suffering from one of these, it isn't as abnormal as it's frequently not as abnormal as for the case of a transmural myocardial infarction. In particular, in a transmural myocardial infarction, the ST segment of the ECG ends up being elevated, and you don't see that elevation with a subendocardial myocardial infarction. Okay, hence why it's called a non-ST segment elevation myocardial infarction. And don't worry if you're a little hazy on what the ST segment of an ECG is, we will go over that in just a moment. Meanwhile, the transmural myocardial infarction on the ECG, this does result in an ST elevation, and therefore its other name is ST elevation myocardial infarction, or a STEMI. So you can use this now interchangeably with the term of transmural myocardial infarction. It means the same thing. Okay, and the aim now of this next video, in this video on coronary artery disease, is to try and explain why in a transmural myocardial infarction you're going to end up with the ST segment of the ECG elevating, and why with a subendocardial myocardial infarction you don't end up with that ST segment elevating. So we will begin with the first question of why does it elevate in a full transmural myocardial infarction, and then later we'll come on to answer the question of why it doesn't elevate in a subendocardial myocardial infarction. Excuse me. Now, to understand this then, we're going to need to have a good understanding of how the normal ECG works. So I do just want to begin off with a little bit of a recap on how the normal 12-lead ECG actually works. So the basic principle then of an ECG, or an electrocardiogram, is that you are going to place two electrodes on the body, okay? And these electrodes are going to measure the electrical potential at those two different areas of the body, and then you're going to attach a lead between those two electrodes, and you're going to measure the electrical potential difference between the two leads, and you'll plot this against time, and that will give rise to the ECG pattern. Okay, so when you look at an ECG waveform, what you're looking at is how the electrical potential difference between two electrodes on the surface of the body varies with time. Now, why do we see the electrical potential difference changing with time? Well, it's because of the electrical activity within the heart, which changes the electrical potentials at the 2 points where the electrodes are, leading to the creation of electrical potential differences between the two. Now, clinically, we do what is known as a 12-lead ECG. And really, in a 12-lead ECG, you are actually doing 12 separate ECGs. You put lots of different electrodes all over the body, and you are looking at the electrical potential difference between loads of different combinations of those electrodes. In particular, you have 12 leads here. Now, each lead represents a connection between two or potentially more electrodes. Really, it's representing the electrical potential difference between 2 points of the body. Okay, so really what we've got in a 12-lead ECG is we're doing 12 different ECGs. We're looking at the electrical potential difference between 12 different combinations of points on the body surface, and we're seeing how they fluctuate with time. Excuse me again. To talk about the familiar pattern of an ECG, I'm just going to take one very famous example of one of the leads in a 12-lead ECG, and then at the end we'll come back to the fact that clinically we use a 12-lead ECG and how that's actually going to be useful in the case of working out where the actual area of infarction is in the heart. Okay, so you're actually going to see the ST elevation for a transmural myocardial infarction if you look at the correct ECG traces of the 12-lead ECG. You need to look at the leads that actually have the vector between the two leads. So if you were to draw a line between the 2 points that you are measuring the electrical potential difference between, you need that line to sort of lie over the portion of the myocardium that has actually undergone the infarction. And I'll come back to an explanation of that later on. Okay, so let's go for a really nice basic lead, the famous one. Whenever you see a classic ECG trace, really that's showing lead 2 of the ECG. If when I did basic medical physiology and I was first introduced to an ECG, we didn't do a 12-lead ECG, we just did a 1-lead ECG, and we did lead 2. We put an electrode on the right arm and we put an electrode on the left leg. Okay, so in a lead 2 ECG, what you do is, if I draw my little stick man here, you put 2 electrodes, one on the right arm here. Okay, so I'll just put his face so we know what direction he's facing, and then we put one on the left leg down here, which I'll just abbreviate to LL. And I have a tendency to look at RA and think right atrium, so if I say right atrium, just fill it in with right arm, I mean right arm. Okay, so in lead 2 of the 12-lead ECG, what we are looking at is the electrical potential difference between an electrode placed on the right arm and an electrode placed on the left leg. And we look at the electrical potential difference from the right arm down to the left leg, and that's very important that leads are oriented. You can't just say one of the electrodes is here, one of the electrodes is here. You have to then also give a direction. You have to be saying from which electrode to the other. So if you like, the vector associated with this lead is this arrow here. Okay, a straight line connecting the two, pointing to the one that you're going to. Okay, so you're taking the electrical potential difference from the right arm to the left leg. And what that means is, if you had a machine measuring electrical potential up here, and that machine moved to the left leg, what would the change be in the number that was shown on the machine for the electrical potential at that point? Okay, so that's what we're actually going to measure in a lead 2 ECG, the electrical potential difference from the right arm to the left leg. And let's just give the explanation as to why this shows this characteristic pattern. But firstly, let me just write out the characteristic pattern here. So here's the characteristic pattern then that a lead 2 ECG will show. So here's the first bit, known as the P wave, like so, and I'll just colour this in. So the first part of the classic ECG picture is known as the P wave. Then you've got a flat portion between the P wave and the beginning of the QRS complex, which represents ventricular depolarization, like so. And it consists of three waves, a Q wave, an R wave, and an S wave, and is therefore called the QRS complex. Then you've got another flat portion, and then you've got the final wave, which is a big one up, like so, and then it will just be flat until you could then start another P wave. So this is one cycle of the heartbeat. Okay, and this final wave here is known as the T wave. And this segment here between the S wave and the T wave, this is known as the ST segment, and this is the portion that's going to end up being elevated in an ST elevation myocardial infarction, in a transmural myocardial infarction, provided you're looking at the right leads in a 12-lead ECG, provided that the vector between the 2 points that you're looking at the electrical potential difference between goes through the portion that has actually undergone infarction. And really you want, well, not just really, what you really want is for it to go through that portion of myocardium last. So if you're following the vector through the myocardium, the last portion of myocardium it goes through before it then goes on to other tissues, you want that bit to be the portion that's undergone the infarction. Okay, so you want the lead that you're going to be over the portion of myocardium that's actually undergone the infarction if you want to see an ST elevation in the ECG for that lead. Okay, so here's the T wave also in pink there, and then we'll have the QRS complex in red. So now what I want to do is try and give you a brief explanation as to why the ECG normally looks like this, and then we'll discuss what's going to happen to cause ST segment elevation within the ECG in the case of transmural infarction. Okay, right, so why does it normally look like this? Well, what we need is another picture of our conduction system in the heart, and I'll just draw a fresh picture rather than skipping back to the old picture. So I'm going to draw the same picture where we have cut through the heart, and it allows us to see all of the chambers of the heart. So here are the two atria, the right atrium and the left atrium here. Here is the left ventricle, like so. And here is the right ventricle, and I'm going to just quickly draw the conduction system for the heart on again, because this is going to be really important in understanding this. We need to have a very good understanding of the order in which the portions of the myocardium undergo the electrical signal. So here I'll have the sinoatrial node, then what we'll have is the atrioventricular node, here in red, the atrial conduction system, so Bachmann's bundle here, the internodal conduction pathways, anterior, middle and posterior, then the bundle of His here, the left bundle branch, the right bundle branch, and now I'll add on the Purkinje fibres, which I'll have in pink here. So let's have some Purkinje fibres, like so, which will pass the electrical signal to the myocardium. Right, so the P wave, it represents atrial depolarization. So at this bit here, this is where the sinoatrial node generates its electrical signal. And when the electrical signal propagates down the wall of the atria, the electrical signal is going to pass from myocardiocyte to myocardiocyte. And in order to pass from myocardiocyte to myocardiocyte, you have to get current spreading from one cardiomyocyte to the next one. Okay, so if I draw two cardiomyocytes like so, in order for one to pass the electrical signal, to pass the action potential onwards to the next one along, it has to have a positive current going through gap junctions. So remember, cardiomyocytes are connected electrically. They have these electrical synapses in between them, known as gap junctions, which I'm showing here in red. So this is representing a gap junction. And gap junctions can conduct positively charged particles. So when this cell has undergone an action potential, the electrical potential intracellularly will be much higher than normal, and indeed there will now be an electrical potential difference between the electrical potential intracellularly in this cardiomyocyte and this one. So positive charge flows from the area of high electrical potential to the area of low electrical potential, So you get positively charged ions moving from one cardiomyocyte to the next, and this will then depolarize the electrical potential difference across the cell membrane of this cardiomyocyte and then trigger it to undergo an action potential. So as the electrical signal propagates from cardiomyocyte to cardiomyocyte, you have this intracellular current moving from one cardiomyocyte to the next cardiomyocyte. Now if you can imagine all of this current summing up into into a total effect for the entire atria, as this wave of depolarization propagates down the atria in this direction, can you imagine that actually we are actually getting overall charged particles in the universe moving in this net direction? Okay, you're getting these intracellular positively charged particles moving overall downwards like so. This is the concept of the cardiac vector, which is a really important concept for understanding ECGs. It's the concept that as the electrical signal propagates, there is current moving from cardiomyocyte to cardiomyocyte in the direction that the electrical signal is propagating, and this current vector, this is what is meant by the cardiac vector. So as the electrical signal propagates down the atria, the cardiac vector, this direction of current movement from cardiomyocyte to cardiomyocyte, is in this direction. Now if you can imagine, overall we are moving current in this sort of direction. Think about where the heart is on this little man here. Current is overall moving in this direction in his body through these cardiomyocytes in this way. Okay, so overall we are moving positive charge away from the right arm and towards the left leg. So we're going to be raising the electrical potential at the left leg, lowering the electrical potential at the right arm. So the electrical potential difference, the amount you'll have to step up in electrical potential when you move from the right arm to the left leg, is going to become greater. It's going to become positive. Whereas previously, of course, the electrical potential at the two areas would have been the same. So initially the electrical potential at the two areas starts off at 0, which is known as like the isoelectric point. So this is the isoelectric line here. Okay, meaning same electrical potential at the 2 points. But now, look, here's the P wave. As the cardiac vector continues in this direction, we're getting the formation of an electrical potential difference from the right arm to the left leg. Now, why does it go? What happens to it? Why does it suddenly go back down to being isoelectric? Well, because electrical potential differences, they are inherently unstable. They make charged particles move, and charged particles will move in such a way, driven by the electrical potential difference, to destroy the electrical potential difference. So when you create an electrical potential difference between these 2 points, when this one's now got a higher electrical potential than this one, that's going to drive positively charged particles all over the body to now start moving towards the right arm and away from the left leg. So we had current moving inside cells in the heart in this direction, and that's what's created this electrical potential difference. Now positively charged particles all over the body, extracellularly, will now start moving in the opposite direction to destroy the electrical potential difference, and that's why it comes back down. So you can only create electrical potential differences transiently because they are inherently unstable. They make the charged particles move in such a way to destroy themselves. Okay, but that's what the P wave represents. It represents this transient electrical potential difference between the right arm and the left leg that is created by the propagation of the electrical signal down the atria. Okay, then we've got this interval here. Now there isn't really a name for that interval. Instead there is a name for the interval from the beginning of the P wave to the onset of the QRS complex, and this is known as the PR interval. It's the interval between the P wave and the QRS complex, and clearly the R wave is the main part of the QRS complex, which is why it's called the PR interval rather than the PQ interval. But it does mean from here to here, not from here to the onset of the R wave, so don't let that confuse you. So this portion of the PR interval after the P wave, this is where the electrical signal is propagating through the atrioventricular node, through the bundle of His, and through the right and left bundle branches. Now here you will be again getting electrical current moving from cardiomyocyte to cardiomyocyte, but there's so few cardiomyocytes that this isn't going to create a noticeable change in the electrical potential difference between the right arm and the left leg. It's only when you get a huge number of cardiomyocytes doing it all at once that it actually sums up to a noticeable effect. and changes the electrical potential difference between the right arm and the left leg. Okay, now the QRS complex here, so in red this is the QRS complex, and this represents the electrical signal propagating through the ventricles, and this is complicated. Why on earth does it look like that? Well, it has to do with the complex order in which the ventricular conduction system releases the electrical signal on the ventricular cardiomyocytes. So the Q wave here occurs because the first portion of the ventricular cardiomyocyte tissue to actually receive the electrical signal and propagate the electrical signal is actually the interventricular septum, the septum between the right ventricle and the left ventricle. So what happens is the left bundle branch here, it has Purkinje fibers which pass the electrical signal onto the interventricular septum cardiomyocytes here. And the direction of propagation of the electrical signal is actually in this direction here. So the cardiac vector is going to be pointing in this direction, the opposite direction. So it's going to propagate up the interventricular septum like so, and that's the first portion of the ventricular cardiomyocytes to receive the electrical signal. So of course that means that you're getting positive charge moving in the opposite direction. You're moving positive charge overall towards the right arm and away from the left leg. So now you create a negative electrical potential difference transiently between the right arm and the left leg, which is why you get this downward deflection here. Okay, right, so that's the Q wave. Then what happens is you get major ventricular depolarization. So the right bundle branch and the left bundle branch, their Purkinje fibers release the electrical signal onto the major portions of the ventricular wall here, and they release it first onto the subendocardial myocardium. So the Purkinje fibers are in the subendocardial portion, the inner portion of the myocardial wall, rather than in the outer portion. So the electrical signal starts from the inner portions and then propagates out to the outer portions. So these are the directions in which you're going to get electrical signals propagating. And you can imagine if you sum all of this, the movement in this sort of direction, the component of the electrical current going in this direction in the case over here, and the component of the electrical current going in this direction over here cancel, okay, so that there's no net movement of current in this sort of axis here, but of course all of the movement in this sort of direction, that sums together. This is just basic vector addition here. So the cardiac vector is then going to point in this direction, and of course that's going to cause an upward deflection. It's going to raise the electrical potential at the left leg, lower the electrical potential at the right arm, and therefore you're going to get a positive electrical potential difference from the right arm to the left leg, and therefore an upward deflection of the ECG trace. Again, of course, it's going to be short-lived because as soon as you create electrical potential differences, they automatically destroy each other by causing charged particles to move in such a way that they destroy the electrical potential difference. Okay, then the final bit, the S wave here of the QRS complex, that's the final portion of ventricular muscle to depolarize. That's caused by the Purkinje fibers releasing the electrical signal up to these posterior portions of the ventricular wall. Okay, so this portion up here and this portion up here. And then again, what's going to happen is it's going to propagate backwards in this direction. So the cardiac vector is therefore going to be pointing in this direction, i.e. towards the right arm and away from the left leg. So you're going to get, therefore, a downward deflection in the ECG trace here. The electrical potential difference from right arm to left leg is going to become negative. Okay, and again, it's short-lived, so you'll go back up to the isoelectric line very quickly. So that's the QRS complex, that's ventricular depolarization. Then in the ST segment, what you've got is all of the cardiomyocytes at this point will be in the plateau phase of their action potential. Okay, so there won't be any current moving between cardiomyocytes, and that's a really important point to note actually, that the ECG really shows currents between cardiomyocytes, and it's showing you the direction in which current is moving between cardiomyocytes, and you need to have a big, vast number of cardiomyocytes that are all conducting current in the same direction. Okay, so it's not showing the phases of the action potential, it's showing where you've got current moving, major portions of current moving around the heart. Okay, right, and when all of the cardiomyocytes here are in the plateau phase of their action potential, there's not going to be any current moving between those cardiomyocytes, so you just go into this flat portion. So that's the ST segment here, where all of the cardiomyocytes are in their plateau phase of the action potential and there's no current therefore. The T wave then represents ventricular repolarization. As for atrial repolarization, that doesn't really ever show up. It doesn't create an effect that is noticeable on the ECG. So you see a wave for ventricular repolarization, you never see a wave for atrial repolarization. So let's just explain ventricular repolarization. So when cardiomyocytes repolarize, so I'll draw another little picture here. Remember, the ECG shows current, so we need to understand how is repolarization going to create current. Okay, so let's say we have these two cardiomyocytes here, and they're both in their plateau phases of the action potential at the moment. And let's say now that cardiomyocyte number 1 has repolarized. Okay, repolarizes before cardiomyocyte number 2. Okay, so it starts to repolarize, but cardiomyocyte number 2 is still in the plateau phase. That means that the electrical potential in the intracellular compartment for cardiomyocyte number 1 is going to go back down to the normal level, whereas the electrical potential in the intracellular compartment of cardiomyocyte number 2 is still much higher than normal. Okay, so that means that you're now going to get positive current moving from the cardiomyocyte that has yet to undergo repolarization to the one that is undergoing repolarization. So you get the positive current moving in the opposite direction. In the case of depolarization, or in the case of the wave of depolarization, the positive current moves from the cell that has depolarized to the one that is yet to depolarize. In the case of repolarization, the positive current moves from the cell that is yet to repolarize rather, to the one that has already repolarized. Okay, so you're going to get currents moving in the opposite direction. This is the one that has repolarized, this is the one that is yet to repolarize. Okay, right. Now, you might expect that in the case of ventricular repolarization, if I was to ask you which cardiomyocytes of the ventricles do you think are going to repolarize first, you might say, well, it's going to be the subendocardial ones because they depolarized first, okay? Whereas the subepicardial ones, they depolarized last, because remember the wave of depolarization spread from subendocardial out to subepicardial. And by the way, we're not really fussed now about the smaller portions of the ventricle, the interventricular septum and the posterior portions. We're really concerning ourselves now with the major portions of the ventricle, which is this portion here and this portion here. Okay, they're the major ones that are going to contribute to the T wave here. Okay, so you would guess that it would be the subendocardial ones that would repolarize first, and the wave of repolarization would propagate outwards just as the wave of depolarization did. You would therefore expect that the positive current would move in the opposite direction to how it moved in depolarization, because remember, we move from the one that has yet to yet to repolarize to the one that has repolarized. So if the subendocardial ones are the first to repolarize, we're going to get current moving inwards. Okay, however, that's not what happens. Instead, it is the subepicardial cardiomyocytes of the ventricle which repolarize first, and the wave of repolarization spreads inwards. Now, the reason for that is that the subepicardial cardiomyocytes just have shorter action potentials. Their plateau phases last for less time, and therefore they repolarize first. So the wave of repolarization does actually spread from subepicardial myocardium to subendocardial myocardium, and for that reason you get overall positive current moving outwards just as it did in the wave of depolarization, because remember, it will move from the ones that are yet to repolarize to the ones that have already repolarized, which is outwards towards the subepicardial myocardium. So you'll actually get a cardiac vector pointing downwards again, and that's why you get this upward deflection here with this current, that is, this cardiac vector pointing down towards the left leg away from the right arm, and therefore you create a positive electrical potential difference between the right arm and left leg transiently, and then of course it returns back to the isoelectric point because of course it's unstable. Okay, so there is a reminder of the normal ECG trace for a lead 2 ECG. Now, going back to the concept then of a 12-lead ECG, this is the classical one. This is lead 2 of a 12-lead ECG. In a 12-lead ECG, you'll have 12 separate pictures, and these different pictures are representing the electrical potential difference between different combinations of points. Okay, so for instance, you could have, instead of doing the right arm and left leg, you could have between the right arm and left arm up here. You could have had the electrical potential difference from there to there. That is in fact lead 1 of the ECG, of the 12-lead ECG. You can also have from the left arm down to the left leg. Okay, this arrow here. That's what's called lead 3 of the 12-lead ECG. So we have loads of different combinations of points where we're measuring the electrical potential difference between to create our ECG basically, and we have 12 different graphs which are representing the electrical potential difference between different points of the body. Okay, now going back to what we're talking about, STEMI and NSTEMI here, if you look at the correct leads of a 12-lead ECG for someone who is suffering from a transmural myocardial infarction, then you will see elevation of the ST segment. Specifically, what you'll see is something that looks like this. Okay, so you'll see no Q wave. The Q wave will have gone, and the ST segment just remains high like this, and then goes straight into the T wave here, and then it comes down. Okay, so instead of looking in this classical pattern, instead you'll have the ST segment up here, and that classical appearance is known as ST elevation on the ECG, and that's the classical way that a transmural myocardial infarction shows up, hence why it's also called an ST elevation myocardial infarction. With a subendocardial myocardial infarction, it does not look like that. You have to look at the right leads, and let me try and explain which leads you need to look at. So let's do this with an example. So if you have got, let's say, a great big portion of myocardium like this that has died. This is the portion that's undergoing the myocardial infarction. Okay, here it is. So this is the ischemic portion. What you need to look at is you need to look at leads where the 2 points that you are looking at the electrical potential difference between, if you were to draw a vector between them, so let's say we've got a point here and we've got a point here, okay, and we are looking at the electrical potential difference between these 2 points. So I'm drawing a vector from this one to this one because we're looking at the electrical potential difference from here to here, just like the way I did between the right arm and the left leg in this picture here. You need this vector to go through your portion of ischemic myocardium, the portion that's undergoing the myocardial infarction. Not only that, but you also need it to be on the far side of the vector. So as I go along this line, this is the last portion of myocardium that this is going to go through. After it, there's no more myocardium. I go into other tissues. So you need to pick a lead of the 12-lead ECG where if you join the 2 points that you are looking at the electrical potential difference between by a nice arrow, that arrow goes through the portion of myocardium that is actually undergoing the myocardial infarction and is ischemic, and it also goes through it last, so it's towards the electrode, if you like, or the point that you're looking at the electrical potential at, that you're going to. Okay, so this is the from point, this is the to point, so this needs to be towards the to point and away from the from point, okay, if that makes sense. So it doesn't need to be perfect. I mean, it doesn't actually have to perfectly go through it. I mean, in this case, lead 2 would probably be perfectly good, because if you think about having the right arm up here and the left leg down here, you know, drawing a line between them, this sort of does lie in the path. It sort of does fit the specification, and you will see the ST segment rise there, and I hope by the time that I've actually explained why it goes up, you'll be able to understand why you need this condition to occur. Okay, so overall, if you've got a transmural infarct, but not just a subendocardial infarct, then if you look at the correct leads of a 12-lead ECG, which are these leads where the arrow between the 2 points of the body that you are looking at the electrical potential difference between, where you're drawing the arrow from the from point to the 2 point, okay, as far as the electrical potential difference is concerned, goes sort of through the portion of myocardium that is ischemic in your transmural infarction, and it goes through it last, so it's sort of towards the 2 electrode and away from the from electrode. Then you will see ST elevation if it's a transmural infarct, but not if it's just a subendocardial infarct. Okay, we will have a break here, and in the next video what I will do is use this understanding that we now have of the ECG to explain why the ST segment is actually elevated in these leads of the 12-lead ECG in the case of a transmural infarct, and why it's not elevated in these same leads if we're talking about a subendocardial infarct.